welcome to The Code Tray, the podcast of the ACCP Emergency Medicine PRN. I'm your host, Christian Kroll, an emergency medicine and ICU pharmacist at the University of Iowa Hospital and Clinics. To view this recorded presentation, head to our YouTube channel at youtube.com/@ACCP EMED-PRN. And for PRN members, slides can be found under the Libraries Entries section of the ACCP Communities website.
We're going to start with Emily Paulus. She's a PGY2 emergency medicine pharmacy resident at MercyOne Medical Center, and she'll be presenting on the journal article titled IV Magnesium Sulfate Improves Orotracheal Intubation Conditions, a Randomized Clinical Trial.
Thank you for having me today. So my objectives include looking at the pharmacokinetics of magnesium and neuromuscular blocking agents for rapid sequence intubation, assessing methodology utilized within the study, and then really making the determination if magnesium is a suitable substitute for orotracheal intubations. So starting off, for rapid sequence intubation, we usually have a sedative and a paralytic agent. These cause skeletal muscle paralysis and facilitate laryngoscopy and rapid endotracheal intubation. They can either be depolarizing or non-depolarizing agents. Typically, what we see for our paralytics would be rocuronium or succinylcholine. When looking at first pass success rates while using an MBA, there's a study that looked at using one versus not, and they found there's about an 80% first success pass rate using the NMDA, where there was just below a 70% with a much larger population study when no NBA was utilized. Overall, the study did have improved odds when an MBA was used for intubations. So it kind of brings up the question, why would there be any contraindications to using an MBA, and why may magnesium be a better choice? Well, when looking at some contraindications, our two agents we can kind of break down. For succinylcholine, there is the risk, especially if patients have a history of malignant hyperthermia, the risk of hypokalemia occurring, and then myasthenia gravis. With rocuronium, there's the increased duration of action, and this could be due to patient having hepatic or renal impairment, and then having that agent act for a longer duration, and then patients that had a previous anaphylaxis reaction while they were given rocuronium. So these together make up just kind of the common contraindications for NDMAs. So now we'll kind of take a look into why magnesium may be a better alternative. So magnesium, like I was mentioning, where it works in the body has a little bit different mechanism of action. And we're really focused on the neurological standpoint for this study. So it depresses the central nervous system while producing anti-convulsant effects. So this is at neuromuscular junctions. It inhibits the release of acetylcholine, blocking the peripheral neuromuscular transmission. So we can give this orally or IV, with the onset being pretty immediate. There are some adverse effects that we want to watch out for that include cardiovascular collapse, hypotension, the risk of respiratory depression, and then pulmonary edema. And monitoring-wise, it's typically done by looking at a patient's vitals and then running a magnesium level via their lab panel. So now we'll kind of look into some previous studies that were done looking at utilizing magnesium. So one was done by Barbados in 2020. That was a double-blind randomized prospective study. They had 68 patients, and they used the ASA, which is the American Society of Anesthesiologists, and they used the classification system of 1 and 2. So 1 would be a healthy patient who is fit, non-obese, non-smoker, and has good exercise tolerance. And they usually typically have a normal BMI, consume no or minimal alcohol, and really have no or minimal functional limitations. And then a type 2 classification would have a patient with mild systemic diseases that don't significantly limit their function. So this could be an active smoker, someone who consumes alcohol, a pregnant person, someone with a BMI around 30 to 40, someone with controlled diabetes or hypertension, or someone with mild pulmonary dysfunction. And these patients in this study had a scheduled appendectomy. They also used the magnesium 50 milligrams per kilogram, and they were comparing it to rocuronium at 1 mg per kilo. In conclusion, they found that the magnesium did not provide adequate clinical status compared to the rocuronium, and most of their patients actually had to be switched to rocuronium after receiving their magnesium. Another study was done by Sultani and authors in 2016, and it was a double-blind randomized protocol. They included a larger study population of 100 patients. And they used the same classification scale by the American Society of Anesthesiologists. They included a type 3, so their patients were considered to be a little bit more sick. And they also had scheduled surgeries, but theirs were ophthalmic. They compared different dosing of magnesium. So they used 40, 45, 50, or 55 milligrams per kilo and 100 mils of saline compared to saline alone. But they had it accompanied with propofol and fentanyl in their transfusions. And what they found was that magnesium with propofol and fentanyl facilitated intubation without needing the neuromuscular blocking agents. But they brought up the question of, was that due to the propofol and fentanyl being on board with the magnesium, causing a little bit more of that sedation and muscle relaxation on top of the magnesium? So that kind of leads us into the purpose of this study, where they're really investigating the efficacy of 50 milligrams per kilogram of magnesium before induction to see if it improves induction conditions without the need for a neuromuscular blocking agent. In this study, it was a double-blind randomized clinical trial that included patients aged 20 to 65 years. All of their patients had the absence of having an anticipated difficult intubation criteria. So these were patients that did not have any anatomical abnormalities within their oral cavity space. The providers classify them as being a easy intubation. And then these patients also were scheduled for an elective surgery. They didn't specify the type of surgery. They just were any type of surgery that required orotracheal intubations. For their patients' exclusion criteria, they put non-inclusion, and then they had patients that were excluded. So their non-exclusion criteria included procedures that were expected to exceed a duration of 3 hours, needing urgent surgical interventions, patients that had a full stomach, anyone anticipated with a difficult intubation, patients with renal disease, respiratory insufficiency, neuromuscular disorders, morbid obesity being defined as a BMI greater than 40, or any known allergies to magnesium sulfate. They excluded patients that had an unanticipated difficult intubation, if they had an unplanned prolonged operation, so an operation that went over that 3 hours mark were excluded, and then if there's non-compliance with the chosen anesthesia protocol, so if they ended up administering an NMBA. So here's the breakdown of their enrollment, allocation, exclusion, and analysis. So they assessed 84 individuals for eligibility. 4 were not included due to just participation refusal. So they had 80 patients that they were randomized into the saline group and into the magnesium group. Here's where that the excluded group kind of comes in. So in both study arms, 2 patients each were excluded due to the intervention or surgery going greater than 3 hours for both of the patients. And so they had a total of 38 that they analyzed. So now we'll kind of take a look at the 2 study arms and what was included in the saline group and the magnesium. So the saline group is what they labeled as their placebo. So they just received 100 ml saline solution over 15 minutes prior to induction, while their active arm was the magnesium, where they received 50 milligrams per kilo magnesium sulfate and 100 mils of saline solution 15 minutes prior to the induction. Their main endpoints that they were looking at was just the overall intubation conditions, so the ease of the laryngoscopy, vocal cord position and or movement, and then response to intubation or cough. So was there a cough present or diaphragmatic movement that they noticed? One thing they also looked at when they're looking into their statistical analysis is they needed at least 34 patients per group to meet power. Here, they use multiple different statistical tests to kind of determine their normal distribution, categorical data, and quantitative variables, which were all appropriate for this type of study. One thing I did want to know as well is they actually used the Copenhagen scale, which came from there's a meeting over in Copenhagen where they came to a classification of what was deemed a easy intubation versus a difficult intubation. And based on that score is how they were able to come up if patients were deemed to have an easy airway versus a difficult airway. So now we'll look into some of the baseline characteristics for this study. So for their ages, they were pretty consistent across the group. There was not much differences. Same with their BMI, sex, and overall ASA classification groups, which again is from the American Society of Anesthesiologists, just determining what the overall patient looked like in terms of health status. Overall, these demographics were comparable along with the types of surgeries, even though they are not listed out specifically within the study. They were pretty comparable across the 2 groups requiring intubation. One thing I did want to know is that most patients in the magnesium group did have a classification of an ASA of 1, so their individuals were healthy with limited comorbidities and non-smokers. So more into the results, looking at the overall intubation conditions, starting off in the magnesium group, most patients were considered to have excellent or good, being 66 or 29% respectively, while in the placebo group, most were within that poor conditions, or which would be about 61% of their patient population. The clinically acceptable is kind of their overall what they thought for their patient population. And in the magnesium group, that was 95% of the patients that they analyzed, where it was only 39% within the placebo. Cough was mentioned earlier as one of their intubation conditions, just going to determine how the patients were reacting. And in the magnesium group, only 1 patient was noticed to have a cough while attempting the intubation, while 13 patients in the placebo group actually did have a cough present. So with magnesium, as mentioned earlier in the slides, it runs the risk of causing hypotension and having an effect on a heart rate. So that's why we usually check vitals. And in the study, they compared them head to head. And what they found was that the hemodynamic variations were very similar in between the 2 groups prior to and after intubation. And they actually did find these to be significant for all 3 of the parameters. What they found is about a minute after intubation and during the first hour of intervals, the heart rate was significantly lower and more stable in the magnesium group than the saline group, which is interesting. But when you look at this chart, they do look very similar. Same with the systolic arterial pressure. As you can see, the magnesium positive is going to be the active arm, and the magnesium negative is that saline group. The saline group did have a little bit of wider margins, but overall, again, they are very similar. And here with the diastolic arterial pressure, kind of the same picture. They're very similar to one another. The magnesium group did have a little bit more of a stable line. A couple other results I wanted to point out is that there was no adverse effects of magnesium or magnesium complications found in either group, and there's no intubation failures in either group. All patients were successfully intubated. The author's conclusions really came to that magnesium is an effective drug for adjunct for tracheal intubations. Patients experience easier laryngoscopies and intubation conditions when it was utilized. The 50 milligrams per kilogram did not cause any significant adverse hemodynamic effects or post-operative complications, and it may be a benefit for patients that are unable to utilize our neuromuscular blocking agents. So looking at the strength of the study is they did meet power. They needed to have 34 patients included in each arm, and they were able to enroll 38. It was a really well-defined study population. Across the board, most patients were falling into criteria being healthy individuals requiring intubation for surgery. And they had appropriate endpoints they were really looking at their diastolic and systolic blood pressures, heart rate, and overall intubation conditions. There are some critiques to the study. So all of their patients were for controlled intubation settings. They excluded any difficult airways that were expected to be present. This makes it very difficult to extrapolate this data into the emergency department or critical care areas due to our patients usually being unstable and needing to have an airway within a specified time period, which causes some difficulty in needing to wait or having the luxury of being able to let the magnesium cause its induction for 50 minutes prior to intubating. Most of these patients also had excellent or good intubation, and a lot of them fell within the magnesium group, which may have skewed some of the data in terms of showing that magnesium had a positive outcome. Their comparator group looked at magnesium compared to rocuronium, which was a very good study in terms of comparators, as they're rocuronium is our usual agent that is utilized. And then it was a small study population. It was done as a single center in another country, so it was not done within the United States, which may again make it difficult to extrapolate to our patient populations. Some thoughts that I had overall is that magnesium may be an option for patients that have allergies or contraindications to neuromuscular blocking agents if you have the luxury of not needing to have an emergent intubation. It did show a benefit for optimal intubation environments. Like I said, if you have that luxury time of waiting prior to having to intubate for these patients, and you do not want to use a neuromuscular blocking agent, you may have a benefit in utilizing magnesium. But further studies are really needed before we can start to extrapolate this data to use for rapid sequence intubations. Overall, magnesium sulfate is an effective drug for adjunct for tracheal intubations. The 50 milligrams per kilo did not cause significant adverse hemodynamic effects or postoperative complications. But to note, in their supplemental data, they did not state what the overall average dose was given or what the maximum dose of magnesium was, and that there may be a benefit for patients unable to utilize neuromuscular blocking agents. Thank you for listening. What questions may I answer for you?
If you have enjoyed this presentation content and would like to hear more, subscribe via your favorite podcasting app. Additionally, make sure to check out our YouTube page for all recorded presentations. Thank you for listening to this week's ACCP Emergency Medicine Journal Club presentation. Join us weekly for review and discussion of new journal articles in emergency medicine. This podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. And the use of the contents and materials in the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users or patients should consult their physician or personal healthcare professional. The user or patient should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guest and should not be interpreted to reflect the official position or policy of ACCP or the Emergency Medicine PRN.